Welcome to the Foot and Nail course. This is section 1 of this course, and in this course we're going to address anatomy and physiology of the structures of the foot and nail, and we're going to look at common pathologic conditions affecting the foot and nail. These are conditions for which you should assess when you're providing foot and nail care, and these are conditions that will be addressed on the certification exam. My name is Dorothy Doty. I'm a CWOCN and a certified foot care nurse, and I'll be walking you through this content. We'll start just big picture, recognizing how amazing our feet are. Obviously, if you're taking this course, you appreciate feet and you're interested in doing foot and nail care. I'm sure you have a number of nurse colleagues who feel exactly the opposite, don't like feet, don't like to do foot care, would hate the idea of doing nail care. So we're glad to have you. There's not that many of us, but we recognize that foot care is very important, and that by doing a good job with preventive foot and nail care, by screening patients for evidence of systemic conditions that could adversely affect foot health and nail health, by screening for localized pathologies, we can many times eliminate problems and certainly prevent serious problems from occurring. As you know, our feet sustain tremendous mechanical stress throughout our lives. From the time we start walking, we stress our feet. And yet, for most of us, our feet last us a lifetime, supporting us whether we're walking, standing, running, jumping, whatever. We're going to talk about some of the things that make that possible. And we're going to start with the bony structures of the foot. Each foot has 26 bones. So that tells you right away that no matter where you are on the foot, you are not very far from a bone. It certainly underscores the fact that osteomyelitis is a very serious potential complication if we're not meticulous in our technique. We're going to look at the specific bones in the foot. You need to know some of these names for the exam, and you certainly need to know what you're assessing when you look at a patient. So first of all, let's look big picture. The toe bones are known as the phalanges. The long bones in the forefoot, so these are the phalanges, okay? And then the long bones are the metatarsals. Then you have the midfoot. You have 5 bones in the midfoot. You have the cuneiforms, you have the navicular, and you have the cuboid. And then in the hindfoot, you have the talus and the calcaneus. Now we're going to look at the forefoot, the midfoot, and the hindfoot in just a little more detail. So of course you have the 5 toes with the phalangeal bones, okay? Then you have the metatarsals, those are the long bones. And when we're looking at the plantar surface and we're palpating just under the toes and we're palpating those bones, those are the metatarsal heads, which you see right here, the heads of those long bones. You should know that the toe bone plus its accompanying metatarsal, the phalangeal bone plus the metatarsal, together are known as a ray. And that's important because sometimes you'll care for a patient who requires a ray amputation. They may amputate 1 or more rays of the foot. And that means the toe bone and the accompanying metatarsal. Of course, when you have all these bones, you have to have joints, so you should know the names of the joints. So you have the distal interphalangeal joints, you have the proximal interphalangeal joints, and then you have the metatarsal phalangeal joints. So pips, dips, and MTPs. So proximal interphalangeal, if you look at this as my toes, then proximal interphalangeal joints would be here. Distal interphalangeal joints would be here. And then, of course, metatarsal phalangeal connection of the toe bone to the long bone in the forefoot. You should realize that the great toe is also known as the hallux. And a lot of the questions on the certification exam relate to terminology. So you probably want to create a list now and start learning all these terms if you don't already know them. Hallux means great toe. In the hallux, as you can see, you have two distinct bones, here and here, okay? There's the two joints, the interphalangeal joints, and you also have two tiny sesamoid bones that allow the toe to go up and down. I think you can see the sesamoid bones, they're right here. Now let's look at the midfoot. So when you look at the midfoot, you're looking at these kind of purple bones here, these 5 purple bones, okay? So you've got the first, second, and third cuneiform bone, and you've got the navicular and the cuboid. I don't think they're going to ask you details about the bones in the midfoot. I think they will ask you or expect you to know the term phalangeal bone, metatarsal. I don't think they'll ask you specifics about the midfoot, but you want to recognize that this area of the foot, this is where you have the arch of the foot. This plays a huge role in absorbing the shock to the foot as we walk, as we run, as we jump. And finally, you want to recognize that the bones in the midfoot are connected to the bones in the forefoot and the bones in the hindfoot by the muscles and the plantar fascia. Now in the hindfoot, you have the bones in red. You have the talus bone and you have the calcaneus. The talus is connected to the tibia and the fibula on top, so when you palpate the top of your foot, you can feel that talus bone, and it's connected to the leg bones, tibia and fibula. And the calcaneus, of course, as you know, is the heel bone. It comes along the outside of the foot. You can palpate the calcaneus. It's the largest and strongest bone in the foot. The other bones you need to know the name of, the ankle bones are known as the medial and lateral malleoli. So you need to know that the malleolus is the ankle bone, the malleoli, plural. The terms I think they will expect you to know: phalange, metatarsal, hallux, calcaneus, malleoli. Tendons, of course, as you already know, attach bones to muscles. Ligaments attach bones to bones. When you think about all the work and all the flexibility that's required of the foot, and you realize you have all these 26 bones working in conjunction with the muscles and the ligaments, it really is a mechanical marvel. Every little element has a role to play in normal biomechanics, normal gait, and normal gait protects us against ulcerations, against injury, against callus formation. We'll come back to that. Okay, now we're going to move on to muscles and nerves. You have lots of bones in the foot. You also have a very good supply of muscles. You actually have 4 layers of muscles on the plantar surface of the foot. And those muscles work with the bones and with the ligaments to support your weight and to handle all of the stress that's exerted when we walk and run. Also think how important normal muscle function is to maintaining the normal contours of the foot and to maintaining normal gait and normal weight bearing. If you look at patients who have diabetic neuropathy, patients who develop motor neuropathy develop deformities of the foot. They typically have abnormal gait, abnormal weight-bearing patterns, which places them at very high risk for plantar surface ulcers. Finally, the nerves of the foot. We know the nerves of the foot play a very critical role. First of all, the sensory nerves send messages to the brain that tell you if there's a problem. Is there a rock in your shoe? You should know that immediately so that you can stop and intervene. Are you walking on very hot pavement? You get a message to the brain immediately, which allows you to intervene and self-protect. The motor nerves, of course, innervate the muscles to maintain the normal contours, the normal shape of the foot. So in our patients who have neuropathy, which is typically our diabetic patient population, but can involve other patients as well, they're at risk for sensory neuropathy, they're at risk for motor neuropathy, and as we'll discuss later, they're also at risk for damage to the autonomic nerves, which control sweat gland function and the size of the blood vessels. So patients who have damage to the nerves that innervate the foot are at risk for a loss of protective sensation. They're at risk for painless trauma. They're walking on a rock, but they don't know it. They stepped on a piece of glass and it embedded in their foot, but they don't know it. They're also at risk for foot deformities like overlapping toes and hammer toes, and for abnormal gait that places them at risk for callus formation and ulcers. And finally, because of damage to the nerves, they're at risk for sweating abnormalities, either dry cracked feet or chronically wet feet, and for a condition known as Charcot foot, all of which we will discuss in greater detail. There are definite changes in the bones and joints that occur with age. And I think you know this already. You know that it's very normal for patients to exhibit reduced range of motion. Their feet aren't as flexible as they were when they were younger. A lot of patients complain of stiffness and pain, and that relates to changes in the bones and joint. In addition, you get relaxation of the ligaments that frequently causes widening of the foot. Most of us do not wear the same size shoe we wore in high school or in nursing school, because most of us now wear a wider shoe. Now go back to your patient who has neuropathy. What if I don't get my feet measured? What if I just continue to buy the same size shoe I've always worn? I've always worn a 7.5. Only now my foot's really an 8 wide. Then I'm placing myself at increased risk. So once again, we'll keep coming back to the fact that patients who lack normal sensory function have to initiate preventive measures to avoid injury to their feet. And we'll go through those in detail. Now we're moving on to vascular structures of the foot. Normal perfusion is obviously critical to skin health and to nail health. And we have a lot of patients who have impaired perfusion. So let's look at normal and the implications for assessment. Now, one thing you should know is that the major artery supplying the foot is the tibial artery. Coming off that tibial artery is an anterior branch which feeds into the dorsalis pedis pulse. The posterior branch of the tibial artery runs down the inside of the leg and is known as the posterior tibialis. Vascular assessment is an absolutely critical aspect of foot and nail care. So before I start doing anything to any client, I want to do at least a screening vascular assessment to rule out significant ischemic disease. If they do have significant ischemic disease, I need to refer them to vascular for further assessment and for further workup. If I detect indicators of diminished perfusion, has major implications for my approach to foot and nail care, in that I'm going to be extremely conservative because I do not want to risk any kind of break in the skin if I have a patient who has ischemic disease. So let's look specifically at where you're going to palpate when you assess for the dorsalis pedis and the posterior tibialis. A lot of you are already very familiar with this, but just in case. So the dorsalis pedis typically runs between the first and second toe over the arch of the foot. Okay, so if you look here, here is the pathway for the dorsalis pedis. So typically we start right at the base between the first and second toe and follow up over the arch. Usually it's most palpable right over the top of the foot, the arch of the foot, between the first and second toe. The posterior tibialis runs right along this path. So it's on the inner aspect of the leg behind the ankle. So the medial aspect of the leg. There's a little groove that runs behind the medial malleolus, the inner ankle bone. So you're going to palpate behind the ankle bone and a little bit Sometimes it's a little bit below, sometimes it's a little bit above, but always behind. So here's the ankle bone. You're going to palpate along this groove. Now let's look at the venous side of the vascular system. So the arterial side, as you know, is responsible for assuring delivery of blood, oxygen, nutrients to the tissues. And then the venous system is responsible for returning blood back to the heart. Now, looking at normal venous function, you actually have three types of veins. You have the superficial veins, the saphenous veins, that are depicted here in light blue. These veins drain the soft tissues of the leg. Then you have the deep veins. They're in dark blue. They are located immediately adjacent to the calf muscle. Whenever the calf muscle contracts, it compresses the deep veins and propels the blood back to the heart. Then you have connecting veins known as perforator veins. So the normal pattern of flow is the superficial veins drain the blood from the soft tissues, shunt the blood through the perforators to the deep veins, and then the deep veins send the blood back to the heart. The deep veins are very well equipped to do this because they're thick walls, so they can withstand high pressures. And because they're sitting right next to the calf muscle pump, or right next to the calf muscle, every time the calf muscle contracts with walking, with dorsiflexion, blood gets propelled back to the heart. What can happen, what can go wrong is if there's any failure in venous return, you can get back pressure where blood shifts from the deep system into the superficial system. The superficial system is not equipped to handle high pressures, and so what happens if blood shunts back into the saphenous veins is the veins dilate rapidly. They can become tortuous. They can turn into varicose veins. And eventually you get back pressure on the capillary system and a whole sequela of negative events. So just capturing again the critical elements of normal function. Here are the things that work together to pump blood back to the heart, which is a pretty tough task because it's going uphill. First of all, the perforator veins and the deep veins are equipped with one-way valves. So when blood is flowing, the valves are open and then the valves close to prevent backflow. That's an important element. If anything damages those valves, it allows backflow and the system begins to fail. The calf muscle pump is another critical element because every time that calf muscle contracts, it propels blood back to the heart. It helps you understand why patients who are very immobile, patients who are obese and sitting in a chair all day, higher risk for venous disease. The normal respiratory cycle helps because during inspiration, the pressures within the thoracic cavity drop, and that invites blood back to the heart. So normally several factors work together: the valves, the calf muscle, and the respiratory cycle. Now we're going to talk about the lymphatic system, which is the third component of the circulatory system, but the one that usually gets kind of overlooked and ignored. However, if you think about all the diagrams you've seen of the circulatory system, you have the arterial side, you have the capillary bed, you have the venous side, and then you also have the lymphatics. Why do we have those lymphatic vessels that then feed through the lymph nodes? Well, during the normal circulatory cycle, on the arterial side of the capillary bed, you have high pressures that force fluid out into the tissues. Forces plasma, some of the blood cells, some of the plasma proteins out into the tissues because of the force, the high pressures within the proximal aspect of the capillary bed. Then on the venous side of the capillary bed, pressures have dropped, and so fluid transfers back into the capillary bed. And that whole exchange plasma out into the tissues, back into the capillary bed, of course helps to deliver nutrients, oxygen, pick up waste products, etc. Here's the problem. Force can push plasma proteins out into the tissues, but then plasma proteins are large molecules and it's very hard for them to get back into the capillary bed. So some of the fluid and some of the proteins get left behind every day. And altogether, you end up with about 200 cc's of fluid that gets left behind in the tissues every day with normal function. That's where the lymphatic system comes in. Notice that the lymphatic capillaries have little open ends, so that makes it very easy for those large molecules, those proteins, to pass into that little lymphatic capillary. So the plasma proteins, the fluid is picked up by the lymphatic vessels, pass through the lymph nodes, and then look, eventually return right back to the venous system. So really, the lymphatic system is kind of the scavenger system. It comes behind. The venous system is like, oh, you left this behind. Here you go. Very important. Now, you can see what would happen if there's a failure of that system. If you get damage to the lymphatic system, damage to the lymphatic vessels, if we strip out a lot of lymph nodes, then we can cause damage that interferes with the body's ability to pick up that residual fluid, the residual plasma proteins. That's lymphedema, when there's a failure of the system and that fluid gets left behind and trapped in the tissues. Unfortunately, it's difficult to treat. Much easier to treat venous edema, because with venous edema, it's water and salt based, and you can literally just push it back into the bloodstream by applying elastic wraps and stockings. Lymphedema, much more difficult to treat because it's hard to push that protein-based fluid back into the capillary bed, back into the bloodstream. So when you see evidence of lymphedema, you're going to end up referring that patient to a lymphedema treatment center. Here's a classic patient with lymphedema where you have massive edema of the leg. It usually starts at the toes, goes to the groin, and is also frequently accompanied by major changes in the soft tissue so that the leg develops kind of a cobblestone appearance. And many times you also have ulcer formation. Now, you may never see these patients, but if you have a patient who comes in who has massive edema from the toes to the groin, who has kind of a cobblestone texture to the skin, who may or may not have ulcers, and that patient's like, I don't know what to do or where to go, you want to be able to refer them, so you need to know who in your area manages lymphedema. Lymphangitis just refers to a superficial infection that follows the pathway of the lymphatics. So typically what you see is that kind of red streak that follows the pathway of the lymphatics. I don't think they'll ask you about lymphangitis. Now we're going to talk briefly about the skin and its appendages. Characteristics of the skin, and we're always trying to keep the skin on the foot and the toes healthy. So we have to go back to what are the characteristics of healthy skin? Well, the skin should be dry, and we don't mean dry and cracked, we mean not wet. Wet skin is skin at risk, and I think you already know this. When the skin is overhydrated, it loses tensile strength, it's very prone to crack open. I know many of you have seen patients who developed a fungal infection between the toes, they trapped moisture between the toes, they got spontaneous fissure formation between the toes. So one of the things we're always doing when we're providing foot and nail care, we check between the toes to make sure the skin is dry, intact, healthy, no fissure formation. We talk to patients about not putting emollients between their toes, about making sure they dry well between their toes. At the same time, we want the skin to be supple. We don't want it to be so dry that it's itchy and they're scratching and it cracks. So we want the skin to have elasticity, to have give. Unfortunately, there are very few oil-producing glands in the foot. So I'm betting a lot of you have to put more lubricating products, moisturizing products on your feet than you do on other areas of your body, because the skin on the feet is commonly abnormally dry. So routine use of moisturizers that will fill the gaps between the cells, maintain an intact barrier, is important. You'll see the second point on this slide is that normally the skin has a brick and mortar configuration. If you think about a brick wall, you think about how important the bricks are, but what about the mortar? Because the mortar fills the gaps between all the bricks. If I chinked away all the mortar, I would lose most of the strength of the brick wall. Anything could pass through. So take that over to skin and think of the skin cells as the bricks, and think of the skin oils as the mortar. Normally the oils produced by our sebaceous glands fill the gaps between the cells. And filling the gaps between the cells, you create what we call an intact barrier, meaning it's very difficult for bacteria to penetrate, for fungal organisms to penetrate, for irritants to penetrate. But if we deplete those skin oils and we don't replace them, then we have little gaps between the cells, kind of chinks in our armor, and it makes it much easier for organisms and irritants to penetrate. So keeping the skin soft and supple not only feels better and looks better, but it's also an important element of skin health. Finally, the skin pH is normally acidic, which is another part of your defense system, because acidity is hostile to bacterial growth and fungal growth. So when you're selecting products, bathing products, etc., typically you will select products that are pH balanced. What's the major function of the skin? In one word, protection. It is the one barrier between your internal environment and the outside world, between all the bacteria, all the fungal organisms, and the soft tissues on the inside of your foot. Looking specifically at the skin layers and functions, again, you will probably have limited questions about these very specific aspects, so we're going to go through this pretty quickly. The epidermal layer is obviously the outer layer of the skin. It's about 5 cell layers. There's 5 distinct layers, 20 cell layers in the epidermis. So let me see if I can clarify that, because I said it kind of backwards. So when you look at the epidermis, they will divide it into the stratum corneum, the stratum granulosum, the stratum spinosum, the stratum germinativum. So 5 subcategories, but altogether the epidermal layer is about 20 cell layers thick. It's very thin. When you think about a blister on your heel, if you've ever gotten a blister on your heel and then that blister pops and separates in that thin layer of skin, that's the epidermis, very thin. The dermis is the inner layer of the skin, and that's the layer of the skin that gives us tensile strength. The dermis contains a lot of collagen, which is a strong connective tissue, as you know, some elastin that gives the skin its flexibility. The dermis is also equipped with fibroblasts that can do tissue repair, with macrophages that can engulf bacteria. Also, located at the very base of the dermis are what we call epidermal appendages: hair follicles, sebaceous glands, and sweat glands. They're called epidermal appendages because, as you can see in the slide, even though they're anatomically located at the very base of the dermis, they're lined with the reproductive layer of the epidermis. You don't need to spend a lot of time on that. I will be surprised if there's any focus on the exam on that. But the next element is very important, and that is the subcutaneous tissue of the foot. The subcutaneous tissue is not part of the skin. It's sometimes called the hypodermis because it actually lies underneath the skin layers. But it's critical because it provides padding and protection against friction and shear. So I want you to notice the normal areas where you have fat pads, and then I want you to compare that to the areas of the foot that come in contact with the walking surface when you're walking. So first you do heel strike, and the thickest fat pad is on the heel. And then you roll up to the metatarsal heads, and you've got padding all along the metatarsal heads, and then you toe off. So you do heel strike, up to the metatarsal heads, toe off. Where do you have fat pads? Heel, metatarsal heads, toes. Exactly where you need it. Now, unfortunately, with aging, those fat pads tend to thin, and many times when you palpate the bottom of the foot, you'll find that there's minimal fat padding over the metatarsal heads, and sometimes minimal fat padding over the heel. And that, of course, increases the risk for damage because you don't have as much protection against friction and shear. So I was checking one lady, and she's like, "What are you doing?" And I said, "Well, I'm checking your fat pads on the bottom of your foot." And I said, "Your fat pads have really thinned out, so we're going to need to look carefully at your shoes and at your insoles." And she's like, "What did you say about my fat pads?" I'm like, "Well, the fat pads on your foot have really thinned out." And she's like, "So how did I manage to get thinning of the fat pads on my foot and none of my other fats thinned a bit?" I'm like, very important question. We want to keep the skin on the feet healthy. We don't want breaks in the skin. We don't want our patients to have fungal infections. We don't want them to have traumatic injuries. So when we're providing foot and nail care and when we're counseling our clients, we want to talk to them about how they care for their feet and how they keep the skin healthy. So cleansing, of course, most of the people are getting in a shower or in a tub. We find that most of our clients shower, but some people get tub baths. So they're usually cleansing their feet on a pretty routine basis, typically 2 to 3 times a week. What they frequently are not doing is drying well between their toes and routinely using emollients and humectants to keep the skin on the foot soft. Now I want to differentiate between emollients and humectants. Emollients are like moisturizers and creams. So if you think of what you do for your face and for your hands, if you put lotion on your arms, on your legs, those are emollient products. So things with dimethicone, with lanolin, with different types of oils, all of those are very good emollients. And what emollients do, the way they work, they penetrate the outer layer of the skin, they fill the gaps between the skin cells, they act as a softening product so that the skin feels softer after you apply them. The other thing that happens is when you apply an emollient and it fills those gaps between the cells, it reduces the rate at which water is lost from the skin. So it actually helps to retain water within the skin and keep the skin cells healthy. So normally we tell patients the best time to apply any kind of lotion, cream, emollient is after your bath. Pat your feet dry, dry between the toes, apply lotion to the skin on the top and bottom of your feet. Humectants are different. Humectants are intended for dry, thick, scaly skin. Humectants act as a de-sloughing agent, and here's how they do it. Humectants actually penetrate the surface of the skin and attract water. And in attracting water, They help to separate that very dry, cracked skin. So you only use humectants in areas where you want to see that dry, that very dry, cracked elephant skin come off. We never use humectants on very fragile skin because we don't want to attract water and we don't want to cause desloughing. We use humectants in areas where we have very thick, dry, callous skin. So over the heels. Sometimes on the lower extremities if there's a lot of thick, dry skin. What are some humectants? The one most commonly prescribed by dermatologists is lacthydrin. The one that is available over the counter is Attractane. Products that can be used that are not classic humectants, but that do help to retain water within the skin and help to soften the skin over time are very simple things like petrolatum products, Vaseline, Aquaphor. People have used Crisco, very thick creams like Eucerin, and then there's a number of very specific commercial products that are intended for very dry feet. But notice when you apply them to very dry feet, they're going to typically be thicker products that you can tell will trap moisture. What else could you do? You could do episodic vinegar water soaks. And when we talk about vinegar water soaks, we're talking about 1 part vinegar to about 4 parts water. We're talking about a brief soak, typically 15 to 20 minutes. Important to be sure that the temperature is controlled because some of these patients are diabetic, so it's critical for us to check temperature. And it's critical when we take the feet out of the water to dry between the toes and then buff. What does vinegar and water solution do? Well, vinegar is acetic acid, and acetic acid is known as a keratolytic. Keratin is, of course, the protein in the skin cells. What vinegar does is penetrates that very dry outer skin layer, takes water with it, and helps to separate that very dry skin from the healthier skin underneath. So routine skincare, clean the skin, rinse the skin, dry, apply an emollient product, your creams, lotions that are oil-based, lanolin-based, dimethicone-based. Extremely dry skin where you're thinking, did you hit up an alligator to get that skin? That's when you think about vinegar water soaks, maybe 2, possibly 3 times a week, followed by light buffing, followed by application of either a humectant product like lacthydrin or Attractane, or a very heavy, thick emollient like Aquaphor, petrolatum, Crisco, Eucerin, one of those. Now let's come to the nails themselves. And you want to know all of these structures because you will have questions about all of these structures. So you've got the nail plate itself, and that's the toenail. So what we call the toenail is officially known as the nail plate. And then you've got the nail bed. So here's the nail plate, here's the nail bed. We're going to talk about each of these. Here's the nail matrix. This is where the new nail is produced. The hyponychium is what's commonly known as the quick. It's the dividing point between the attached nail and the free nail. The nail folds are, of course, the skin on either side of the nail. And then the free border is where the nail has separated from the skin and it's safe to cut. So we're going to talk about each of those in a little bit more detail. So first of all, the nail plate itself, the toenail, there's 3 overlapping layers. It's a modified form of skin, and you have these cells that are filled with very thick keratin. So it's keratinized cells that literally provide protection from friction, pressure. Otherwise, you would have some very sensitive toes. Notice that toenails are normally 10 to 30% water. If the water content is diminished, then the nails become very brittle. If the water content is increased, the nails become very soft. So think about when you've been wearing gloves all day long and sweating inside the gloves, and the only time the gloves are off, you're washing your hands. And some of you have developed very thin nails that split very easily. It's just because of the increased water content. Now let's talk about the nail bed. The nail bed is the support surface for the nail plate. And of course the nail is firmly attached because there's an interlocking configuration between the nail bed and the overlying nail plate. So normally you cannot separate the nail from the nail bed. It's locked down. So again, nail bed, that's the skin. Nail plate, that's the nail itself. Now, the nail matrix is the reproductive area of the nail. You can see it here in red. I'm going to show you here as well. So, the reproductive area extends from an area about 8 millimeters or 0.8 centimeters proximal to the cuticle to the distal end of the lunula. And you know the lunula is that little white crescent. So the reproductive area of the nail starts just proximal to the cuticle and extends to the distal end of the lunula. This is where new nail is being produced. This is where we can affect the new nail. So a lot of times if you're treating a fungal infection, the instructions will be to apply the topical agent along the base of the cuticle. That's the area at which it can penetrate and affect the developing nail. The nail folds are the folds of the skin adjacent to the nail. We've already said that. Now notice that the proximal fold is continuous with the cuticle. The cuticle actually helps maintain a tight seal so that there's no penetration of bacterial organisms. So the cuticle is an important element of that barrier function. Notice what happens when the cuticle is cut, or people chew the cuticles or pick at their cuticles, then many times they get an infection running along the cuticle. We try never to cut the cuticle. If you cut it, you have to be extremely careful because that is part of the protective system. So it protects the nail bed by literally lapping over and coming back so that nothing can penetrate. Now, the free border, this is an important concept for us. So you know that the nail is locked down until it gets to the end of the toe or the finger, and then it projects past. And there's a section of the nail that separates from the underlying skin. So the nail the distal end of the nail, where it's separate from the underlying skin, that's known as the free nail border. And when we're evaluating a patient and we're looking at their nails and we're determining where we can cut, we're looking at identifying that free nail border. So on the diagram, here is the free border, the part that is not attached to the underlying nail bed. So here's the nail plate, okay, and here's the free nail border. And here you can see it is the white edge. It's like, so this is attached, this is attached, this is attached, free, free, free. Attached, free, attached, free. Notice that much more of this is somewhat free. This patient has a fungal infection. We'll come back to that. Attached, free. So we'll spend time talking about how you evaluate the free nail border. You want to be very clear about where it's safe to cut. What's the rate of nail growth? Usually about 2 to 3 millimeters a month. It takes about 18 months to grow a new toenail, which is a long time. That's why it takes so long to treat a fungal infection in the toenail, because it takes so long for a new nail to grow out. So if we're using topical therapy, like we can use menthol-based products, over-the-counter chest rubs that have menthol, or the over-the-counter agents that can be used because they penetrate the nail bed along the cuticle and kill the fungus. There's a number of topical treatments, tea tree oil, we'll talk about some others. But we have to tell the person it's going to take a long time. This isn't a quick cure. Even if they're using oral agents to kill fungus and to treat toenail infection, it's not a quick cure. They typically do cyclic therapy, checking liver function, etc. So it takes a long time. We have to tell patients it's going to take a long time. Interestingly, in cold climates, it takes longer because apparently you don't grow nails as fast when it's cold as you do when it's warm. Now we're going to shift and we're going to talk about common pathologic conditions that can affect the feet and the nails. And we're going to start by looking at systemic issues that can impact on the skin and nails. And then we're going to look at specific skin conditions, specific conditions of the nail, etc. So looking first at systemic factors, certainly problems with vascular supply, either with arterial perfusion or venous return. Here you see the evidence or the outcomes for a patient who has peripheral arterial disease. So we've already talked, it's critical to have normal perfusion. That's how you get oxygen, nutrients out to the tissues. Here's the normal circulatory system. You can see nice blood supply to the foot. You can see that anterior branch, posterior branch we talked about. Here's a normal vessel. Here's a vessel with advanced arterial disease, and you can see a lot of plaque formation that is narrowing the vessel wall and reducing the amount of blood that gets out to the tissues. When you have a patient who has peripheral arterial disease, they end up with chronically ischemic tissues. Chronically ischemic tissues are extremely vulnerable. Minor trauma can create a non-healing wound. A minor break in the skin can create an infectious process that's very hard to eradicate. That means that as a foot and nail care nurse, I have to be very careful in working with patients who have diminished perfusion. I have to check perfusion status for every patient. I have to do at least a screening vascular assessment. If I have evidence of diminished blood flow, I'm going to be extremely cautious and conservative in my approach. I'm also going to make sure that that patient is being seen by vascular, and I'm going to support other members of the team in providing education and counseling regarding smoking cessation if that's an issue for that patient. This is the foot of a patient with peripheral arterial disease, and I hope you can appreciate that this patient has dependent rubor, very thin, shiny skin, no hair on the feet, thin nails. This patient's very vulnerable. Now, there are some specific vascular disorders. You might be asked about these. The one I think you're most likely to be asked about is blue toe syndrome, so I'm going to start there. This represents an acute ischemic process where the patient's thrown a clot to the vessels to a distal toe or the distal foot. I don't think you'll have a patient who is dealing with an acute ischemic episode. I don't think they'll come to foot clinic, but if they do, if they come in and they have a toe that is cyanotic or distal foot that's cyanotic, and it's cold and there's no pulse and it's painful and this is newly occurring, urgent vascular consult. Berger's disease, you're probably familiar with this, also known as thromboangiitis obliterans. If you look at this slide on top, this is seen almost exclusively in young and middle-aged adults who are heavy smokers. And it's related to constriction of small vessels affecting toes and fingers. There are some other things going on as well, an inflammatory process, but smoking seems to be the trigger. And for most patients, when they stop smoking, their symptoms go away. So the issue is that you can get patchy areas of necrosis on the toes or fingers. Bottom line for a foot care nurse, if I see evidence of peripheral arterial disease, I'm going to make sure that patient is either being followed by vascular or gets referred to vascular. If I see necrotic tissue, and I'm not also a wound care nurse, I'm going to refer that patient to vascular and to wound care. Raynaud's, many of you know someone, some of you have Raynaud's yourself. People who get vasospasm when they're exposed to cold, and sometimes in response to stress. So suddenly you have fingers that are pale or cyanotic and have practically no feeling in them. You can get brittle nails. You don't typically get in tissue necrosis. It does not typically affect what we can do in terms of foot and nail care. On the other side of the vascular tree, on the other side of the capillary bed, venous insufficiency. So, blood flows in normally, okay, but because of a problem on the venous side of the capillary bed, you've got damage to valves, you've got venous distension, so you get back pressure on the capillary bed. When the capillary bed is overly distended with fluid, it forces fluid out into the tissues. So what do we see? We see edema because fluid gets forced out into the tissues. Along with the fluid, you get red blood cells, white blood cells forced out into the tissues. The red blood cells break down, leave their pigment behind, and that causes a change in color of the tissues known as hemosiderosis. And you can see hemosiderosis very well here. You can see it a little bit here. But that it looks like a bruise, kind of gray, brown, black discoloration of the tissue, and it's simply because of the pigment and the red blood cells. Patients frequently ask, is this going away? No, because it's in the deeper tissue, so it doesn't go away. You may also see this in a patient with chronic venous disease, where you have venous dermatitis. It affects the sock area of the leg. You frequently have this scaly skin. A lot of times you have some underlying erythema. The patient complains of a lot of itching, and sometimes you'll have little pinpoint ulcerations. When we see changes like this, if we're not in a wound center, we need to send that patient to vascular or to a wound center to have their underlying venous insufficiency worked up and managed. Worst case, they can come in with an ulcer. So venous disease is manifest by edema, hemosiderosis, dermatitis, and possibly ulceration. They have to be followed by a vascular and wound care team. They're going to need compression therapy. That's like stockings and wraps, as many of you know, that will force fluid out of the tissues back into the bloodstream. Elevation, ankle pumps, as well as wound care. Other systemic conditions that can affect the skin and nails and that have implications for us in managing these patients, autoimmune conditions such as scleroderma. So a lot of you have cared for patients with scleroderma, and you know that the soft tissue loses all of its pliability. And so it's like the skin is stretched tautly over the tissue. Most of these patients are on anti-inflammatory agents for treatment, so they may be on steroids or other high-dose anti-inflammatories. Wound healing is always delayed because of the changes in the soft tissue, the hardening of the soft tissue. Wound healing is also delayed in patients who are on long-standing high-dose anti-inflammatories. What are the implications for us? We need to be particularly cautious. If I'm paring a callus, I'm going to stop sooner because I don't want to risk nicking the skin. I'm going to be very careful in cutting the nails or debriding the nails, not to abrade the skin. So extreme caution and a more conservative approach. You'll see a number of patients with arthritis, and almost always on the exam there are some questions about differentiating the different types of arthritis. So of course you know that rheumatoid arthritis is usually pretty obvious. It typically affects hands and feet. You have major deformities, significant pain. Osteoarthritis, which is not on the slide, but that's typically manifest by stiffness, primarily in the larger joints, and you may see bone spurs. Gouty arthritis most commonly affects the great toe, the first metatarsal phalangeal joint, so this joint right here. This is also known as podagra, P-O-D-A-G-R-A, gouty arthritis of the first metatarsal phalangeal joint of the great toe. Very, very painful. If a patient should come in and is not already being seen by a physician, certainly you want to refer them to a physician. They need to be seen because they're going to require medical management, something for pain, but also underlying treatment. When we see gout, we know that the patient has high levels of uric acid production. And what we typically find is that you have uric acid deposits in the joint. Sometimes you'll even see a break in the skin and those uric acid deposits start draining out onto the skin. It looks like kind of a thick white paste. Bottom line, anytime you have a patient who comes in with an acute process, your goal is, are you being seen for this? Who is taking care of this for you? Who is managing this for you? Have you notified them of this current problem? If you don't have anyone, let me see if I can help you find someone who can help you with this, because gout requires medical management. They have to be on medications to reduce uric acid levels. They need pain medication, and sometimes they need acute drainage of those deposits. Other systemic conditions that can impact on the health of the skin and the nail. Any condition that alters sensory function, sensory awareness, and of course the most common is sensory neuropathy, which we see frequently in our diabetic patients. We can also see it in patients with other metabolic syndromes, such as B12 deficiency. We can see it in patients with severe alcoholism. And sometimes we see it in patients and we don't know why they develop neuropathy. But one of the things that we'll talk about in a later session is screening for neuropathy. We always need to know about sensory function because it has major, major implications for footwear, for patient education and counseling. Any patient who lacks normal sensory function is at high risk for painless, unrecognized trauma. So we've had many patients who came in, they had thick calluses on the plantar surface. It was clear that they had had bleeding into the calluses, and when we took down the callus, there was a major ulcer. So you can have patients with unrecognized ulcers, you can have patients with unrecognized penetrating trauma. You always are very alert to sensory function because it's going to impact on your care and education. Any condition that affects hygiene, nutrition, and self-care. So what about your patients with dementia? A lot of you will end up seeing clients who are much older and who may have progressive cognitive decline. And that's definitely going to manifest in their ability to provide appropriate self-care. Any patient who has a clotting disorder, your patients who are on anticoagulants, your patients who have bone marrow suppression secondary to chemotherapy, all of those patients are extremely vulnerable. What are the implications for us? I need to know that that patient is on an anticoagulant. I need to know that that patient's on chemotherapy. How will it alter my approach? I'm going to be extremely conservative. I will not risk trauma to the skin. Okay, now we're going to move from general considerations, and we're going to talk about specific pathological conditions affecting the feet and the nails. So we're going to start with gait disorders. You're always watching your patients walk. So if you're helping them to the chair, you're watching them walk. If they're already sitting down, you may very well have them stand and watch them walk. Especially if you find altered wear patterns on their footwear, or you see callus formation on the bottom of the foot, important to assess their gait. Excessive pronation, which is what you see here, so that with walking, with weight bearing, my foot, I've got eversion, my foot turns in, and I lose the arch. The problem is that when you get excessive pronation, you have high pressures against the plantar surface and a lot of stretch on the plantar fascia, connective tissue. Patients who have excessive pronation, who do this when they walk, need to be referred to an orthotist. Orthotists are the specialists who evaluate footwear and insoles. And most patients with excessive pronation require orthotics. They may also benefit from foot exercises. The next condition we're going to talk about is disorders of the sweat glands. And you'll have a number of clients who ask you specifically about one of these issues. Hyperhidrosis is excessive sweating. Patients who have hyperhidrosis say that their feet are always wet. When you assess between the toes, you may find moisture accumulation and fissure formation. So when we have a patient with hyperhidrosis, our focus is on just keeping the feet drier. So we're going to talk to them about wearing cotton socks or wearing socks that actually have the capacity to wick moisture away from the feet, about avoiding shoes that trap moisture, so it has to do with their footwear, with their socks, keeping their feet clean so that they don't get overproduction of bacteria. They can use foot powder very cautiously because they don't want it to clump between their toes, so they just have to be careful. A much more serious problem than hyperhidrosis is bronchidrosis. Bronchidrosis is smelly feet. Now, most patients with bronchidrosis also have hyperhidrosis because when you have overproduction of sweat, it creates a wonderful medium for bacterial growth. So most of the time when you have patients with bronchidrosis, you're trying to keep the feet drier and keep bacterial counts low. So these are patients that we would say, we want you to wash your feet with an antibacterial soap, rinse your feet, dry well between your toes. We want you to routinely use an antiperspirant to your feet. Patients with hyperhidrosis can do this as well, not for the deodorant effects, for the ability to reduce sweating. So it should be not just a deodorant, an antiperspirant. And the antiperspirants that spray on in light powder form are particularly helpful and easy to use. Change their socks frequently, and then there's a number of specific products that are indicated for management of bronchidrosis. A lot of them have the word brom or bromi in the name. So B-R-O-M-I, B-R-O-M. So bromi talc is one, bromi lotion is an antiperspirant. A lot of times you can see products in the foot care section, or you can go to a podiatry catalog. There are some prescription level products that are indicated for patients who fail to respond to over-the-counters. Most people respond to over-the-counters. And then anhidrosis is where you have dry feet, and we've already talked a lot about how we're going to manage dry feet. Appropriate use of emollients, and if they have very dry feet, appropriate use of humectants. Humectants, remember, like black hydrin, attractant, your urea-based products that attract water, or very heavy-duty emollients like your Aquaphor, your Petrolatum, your Crisco, some of your very specialized foot care moisturizers. What about fissures? Fissures are common and they're problematic because anytime you get that crack in the skin, it almost always penetrates down to viable tissue, which means it creates a portal of entry for bacteria. We see this a lot in our diabetic patient population, and that's also a patient population high risk for infection. So we've got to manage fissures effectively. I want to separate treatment into initial treatment that you would do as the foot care nurse and then ongoing treatment that the patient could provide. As the foot care nurse, you would want to pare the sides of the callus down. Take off as much of that dry skin as possible so that you reduce the depth of the defect. You don't want something that's like this because that just invites bacteria. So if I can shave it way down so that I create a very shallow crack in the skin instead of a deep crack, that's helpful. So first shave down, pare down each side of that fissure. Clean it very well. Now, it is like a wound until we get it resurfaced. And so until it's resurfaced, you want to dress it with something like a thin hydrocolloid, a thin adhesive foam. But you don't want to just leave it open because then it's open to bacterial invasion. Okay, so let's say I've done paring, I've done the dressing, I brought the patient back, I did repeat paring, and now it's epithelialized. So I no longer have that open wound. Now I want to teach the patient to use a pumice on a routine basis to keep that callus pared down and to use emollients to keep the skin soft. What about blisters? The difference between a blister and a callus: a blister is an acute friction injury, a callus is chronic repetitive response to friction. The big question, should you pop the blister? Should you unroof the blister? And the answer is almost always no. You want to leave that skin layer intact. Leave the blister unroofed, allow the fluid to reabsorb on its own because the intact skin is a bacterial barrier. So typically we do not unroof a blister unless it's very large and very tense and very high risk for rupturing on its own. In that case, the best way to do it, clean the skin very well with alcohol, let it dry. Use sterile needle and syringe to aspirate the fluid, and then cover with something like a transparent adhesive dressing, oxide, tegaderm, biocclusive, whichever one you have, so that you eliminate the risk of bacterial penetration. Let's say it's a mid-sized blister or a relatively small blister, so you already know you're not going to open it. You told the patient, don't open it. We're going to let this resolve on its own. We're going to figure out what caused this blister so we can correct it. If it was footwear, I'm going to send you to somebody who can correct your footwear. I'm going to have you wearing thick padded socks. But also very helpful to take that same transparent adhesive dressing and just apply it as protection. It's like an extra layer of skin. So when any friction is exerted against the skin, it doesn't go to the skin, it goes to that dressing. So typically you do want to stock some transparent adhesive dressings so that you can provide appropriate management for blisters. What about calluses? So here's something that you're going to see a lot that I've already referenced. Here's thick callus formation. You've got callus here, callus here, callus here. You can see in the center where this patient has bled into the callus. So you know that most likely there's an ulcer underneath. And usually what happens, you'll take off layers of dry skin, and some of those layers of dry skin will have dried blood where the patient bled into that layer of callus. And then when you get down, you frequently have an ulcer. If you're a wound care nurse, you're equipped to manage that. If not, you're going to refer the patient for wound care management. So with callus, I'm going to pare down the callus so that I eliminate that ongoing source of friction and shear to the underlying tissue. If I leave the callus, every time the patient takes a step, it's like walking over a rock, over and over and over. And so you get shear and friction, shear and friction, shear and friction. You're just maintaining the cycle of injury. So I have to pare down the callus, and then I have to evaluate footwear, send the patient to an orthotist, have their footwear evaluated, have insoles evaluated so that I can more evenly distribute pressure and eliminate the source. There's a specific type of callus known as an IPK, intractable plantar keratoma. And you can see these here, and I know you've seen these. They're very well demarcated, well circumscribed calluses. And they match an underlying bony prominence. So you can feel them, and then you can palpate, and there's an underlying bony prominence. Now again, you have to pare it down. These are the types of calluses that sometimes you can take the tip of the scalpel and kind of flick out the core. It feels like almost like there's a core because this is a deep callus. But again, I've got to also look at the cause. So I want to have the patient's footwear evaluated. I want to have their insoles evaluated. So most of these patients need to go to the orthotist to be sure that they're in the right shoes and the right insoles. Now, what is the difference between a callus and a corn? And the answer is location. The pathology is exactly the same. It's repetitive friction so that the skin builds up extra layers as its self-protection. Calluses occur on the plantar surface and the sides of the feet. Corns occur on the tops of the toes and between the toes. So the difference in corns and calluses is literally location. Now notice that there are other terms for corns and calluses. So calluses are also known as tylomas, T-Y-L-O-M-A, and corns are also known as helomas. But I don't think you'll see that terminology. It's not widely used. I would expect you to see the terminology corn and callus. If you've already been doing foot and nail care, or if you're a wound care nurse, you've probably seen patients who have hard calluses, and you've probably seen patients who have soft calluses. Hard calluses most commonly occur on the tops of the toes where they rub against the shoes. Soft calluses typically occur between the toes where they're rubbing against each other. Both can be very painful. Soft calluses I find more difficult to manage simply because it's between the toes, and so you have to be very careful when pairing, since you're frequently right there at the web space and you've got that toe right next. You've got two toes in close proximity and you're frequently down close to the web space. So you have to be very careful. You do have to pair that corn to eliminate the source of trauma. And then you have to find some way to eliminate that ongoing friction. So frequently we will use little soft sleeves for the toes, little foam sleeves to separate the toes, little gel sleeves to separate the toes. Sometimes you can use gel spacers. Somehow you have to stop that ongoing friction. Plantar warts are frequently misclassified as calluses. Patients sometimes think they have a callus when they have a plantar wart. Sometimes they think they have a plantar wart when they have a callus. The difference is that a plantar wart is a viral lesion. And one of the ways you can differentiate are these little black dots. These are little capillaries throughout the plantar wart. Now, we manage them much like calluses initially because they do create callus formation that is then a source of trauma to the soft tissue when the patient walks. So usually from the patient's perspective, getting that plantar wart pared down to eliminate the repetitive pressure on the soft tissue of the feet. That's usually the most important thing. But in terms of definitive treatment, we typically refer to podiatry. Now, you've probably heard of all kinds of things that you can do. There's over-the-counter treatments. Some people paint with nail polish to close off oxygen supply, but of course oxygen comes from the inside of the body as well. Same thing with duct tape. They'll talk about taping it up with duct tape to cut off oxygen supply, but again, not the only source of oxygen. So there are a number of topical treatments that the podiatrist can provide if this is problematic to the patient. If it's spreading, then you refer. I guarantee you will have a number of questions about tinea pedis because this is an incredibly common infection. Tinea pedis, fungal infection of the skin of the foot. So risk factors, of course, diabetes, wet feet, immunosuppression. Some patients just seem genetically more predisposed than others. The elderly seem more vulnerable than younger individuals. If it is chronic tinea pedis, it typically is going to present in this moccasin distribution, the bottom and the sides of the foot. And typically is kind of this dry, scaling appearance. But when you look carefully, you'll see these little circular scales all over the bottom and the sides of the feet. Looks bad, dry, scaly, ugly. Usually not problematic to the patient. Typically chronic tinea pedis, they're not complaining of burning, they're not complaining of a lot of itching. So treatment, I guess, is somewhat optional. We typically do treat with a topical antifungal, but again, not really problematic to the patient. Acute tinea pedis, you're going to see lesions between the toes. You're going to see blistering and denudation. This is acutely painful. This is when their feet burn and itch and hurt and they get those cracks in the feet. This is miserable. And definitely you're going to treat them. You're going to treat with an antifungal. An over-the-counter antifungal is usually sufficient. You have to emphasize the importance of keeping the skin clean and dry, changing their socks frequently, using an antifungal spray to their shoes. Ideally, they would throw those shoes away, once the fungal infection starts to respond to treatment. You'd like to get them into new shoes at that point. One other tip I learned from an NP who I heard teaching a patient when we were doing foot care for the homeless. He was managing a patient who had acute tinea pedis. And he was reminding him how important it was to treat his feet and put on his socks before he pulled on his underwear. Because he was pointing out to him, if you pull your underwear over your feet with this really bad fungal infection, guess where else you're going to have it? It was the most attention that patient paid to anything that was said to him in the entire stay. And I thought it was a really good point. I don't think you'll have questions about psoriasis, but here's the bottom line. If your patient has psoriasis, you need to know that they can develop psoriasis, both psoriatic plaques and pustular lesions on their feet, and they can develop painful fissures. So if you have a patient who has psoriasis and they're developing psoriatic lesions on their feet, you want to say, are you being treated by a dermatologist? If so, let your dermatologist know it's affecting your feet. You can, of course, talk to them about some of the over-the-counter things, but you would really rather them be managed by a dermatologist. Now, pigmented nevus versus melanoma, of course, we see a lot of patients who have very simple moles, and nothing needs to be done. All we have to do is make a notation and monitor for any changes. So here's classic moles, okay? Notice that they're well circumscribed, okay? The color's pretty much the same throughout, and they do not change. In contrast, melanoma is characterized by A, B, C, and D. And what does each letter stand for? A stands for asymmetry. So one side of the lesion looks different, has different contours than the other. Border irregularity. You can't draw a clear line around it. Color differences, either that black pigmentation or variable pigmentation. And diameter progression, okay? So it does not stay the same size. So if I see lesions, I make a note, I watch those lesions. If I have any reason to be concerned, I tell the patient, I want you to go to dermatology. I don't think this is anything, I just want you to get it checked out. Here you've got clear-cut indications. That doesn't look remotely normal, that doesn't look remotely normal, nothing like a mole. This is like, demonstrates that asymmetry and border irregularity. And then this I put in because you can also get melanoma involving the nail. Now, melanoma involving the nail could be confused with splinter hemorrhages when patients get trauma to the nail and they bleed into the nail bed underneath the nail plate. It tends to follow a groove and it looks just like a splinter. But splinter hemorrhages grow out. So you can tell the patient, I'm going to make a little mark here and I want you to look at it in 2 weeks. I want you to call me back and I want you to tell me if anything has changed. Because what should happen is that splinter hemorrhage should have grown a little bit out. And so they should say, oh, the mark, there's a little gap between the mark and that area on my nail. Any questions? Refer. Anytime you're not sure, refer. It's never ever wrong to refer. That's the best thing to do for your patient, and it's also the best answer on the exam most of the time. Cold injuries, there usually are some questions about cold injuries. No matter where you live, you may have patients who are exposed to cold intermittently. The question I think you'll get is related to chilblain, also known as pernio, P-E-R-N-I-O. And this is a mild cold injury. You see these purplish blotches, okay? And a lot of times they complain of kind of burning discomfort. All they have to do is keep their feet warm and those changes in the skin and soft tissues will resolve. And then you just counsel them about preventing recurrent episodes. You know, wear warm socks, wear shoes, don't stay outside for prolonged periods of time. If your shoes get wet, you need to get inside, that kind of thing. Frostbite is a severe injury. As foot care nurses, we're never managing frostbite. Those patients are always managed in advanced wound care centers. And you would never wonder, is this something I can manage? Because you've got clear-cut, massive injury to the skin and soft tissues, and you're going to know immediately that patient has to be referred. Bony deformities, go over these pretty quickly. They usually ask several of these terms on the exam. Pes planus is flat foot. Now I want to differentiate between flat foot and excessive pronation. If you have a patient with excessive pronation when they're standing or walking, the medial aspect of their foot is in contact with the floor and the arch is gone. But at rest, you can clearly see the arch. In contrast, look at this guy. He's at rest, he's not weight-bearing, there is no arch. That's a true flat foot, pes planus. Pes cavus is an exaggerated arch, claw foot. You should just know those words. Hammer toes, you should definitely know what hammer toes are. I think you already know what they are. They're flexion contractures of the proximal interphalangeal joint, so that you get these little kind of cocked up toes. They start out being flexible, and at that point, you can do exercises to maintain normal toe structure and to prevent progression. Most people don't do the exercises, don't get anything done, and those soft, flexible hammer toes become rigid. The toes become fixed in that contracted state. Once you have the rigid hammer toes, of course, the problem is that the patient is going to require a shoe with a deep toe box to prevent trauma to the tops of the toes. And once they become rigid, the only management is surgery. Mallet toe is different than a hammer toe. Hammer toe is a flexion contracture involving the proximal interphalangeal joint. Mallet is a contracture of the distal interphalangeal joint. Okay. Just need to know what that is. Hallux valgus, I am confident they will ask you. Remember, hallux is the term for the great toe, and valgus means deviation from midline. So hallux valgus means deviation of the great toe away from midline. Okay, see if I can do this, toward the fifth toe. Or why don't I just show you on the slide since that's much easier. So here's hallux valgus. You can see deviation away from the midline, deviation away from the midline, increased prominence of that first metatarsophalangeal joint, the bunion bone. So a very common bony deformity, hallux valgus. Great toe deviates, the first metatarsal head enlarges. Patients will frequently say, what can you do about my bunion bone? Nothing. I can show you how to protect it. I can talk to you about your footwear, but if you want that bunion corrected, it's a surgical procedure to correct the bunion. Overlapping toes are another very common defect and one that we have to pay a lot of attention to because those overlapping toes trap moisture. The overlapping toes create friction injuries. They create injury to the top toe where it rubs against the shoe, so we have to find some way to protect the toes from each other, typically with protective sleeves. Morton's neuroma, they may or may not ask you. This is a very painful foot condition. It involves progressive trauma to the interplanar nerve. And it's the nerve that is supplying these two toes, third and fourth toes. So patients with Morton's neuroma have no pain at rest. And even when they start to walk, they don't typically have pain when they begin to walk. But as they keep walking, they start with this kind of tingling, burning, stinging, and then it gets progressively worse. So what can they do about this? Well, typically they can do cortisone injections for temporary relief because you've got a lot of inflammation. But the bottom line is you've got a lot of scar tissue that's putting traction on the nerve. So long-term relief, if they have a lot of pain that matches Morton's neuroma, long-term relief usually requires surgical resection of the scar tissue and part of that nerve as well. So again, from our perspective, what's our responsibility? Recognize that this is a condition that requires referral. So the patient says, I have pain with walking. Well, tell me more about the pain. Where is the pain? Well, it's these two toes. When does it hurt? Well, it doesn't hurt at all if I'm sitting. When I first start to walk, it doesn't bother me too much. It gets worse and worse and worse. I'm going to refer that patient. This is nothing I can fix. Plantar fasciitis involves inflammation of the fascia. You've probably known people who've had plantar fasciitis. You know that what happens is, especially with excessive pronation, you get a lot of stretch on the plantar fascia, and so you get little tears in the fascia. And those little tears create intense inflammation. Now during the day, you keep walking on it, so the fluid that normally would accumulate as a result of the injury and inflammation really doesn't accumulate because you're keeping it pressed out. But at night, it does accumulate. And so when you stand up the next morning and you put weight, you've got all that fluid in the area, and it creates intense pain. So people with plantar fasciitis typically have intense pain in the morning that gradually gets better. And they usually need exercises and orthotics so that it corrects their gait. Now, the last thing that we're going to talk about today is conditions of the nail itself. So we're going to talk about conditions of the nail surface. We're going to talk about the way the nail grows. Onychorhexis is these longitudinal ridges in the nail. So it's base to top. Sometimes we see that in patients who have lower extremity arterial disease, very thin nails with little ridges. We can also see that in patients with psoriasis. And when we see it in patients with psoriasis, it's known as onychorhexis. Those are the longitudinal lines. Bowes lines are these transverse lines. Sometimes you'll see just one, sometimes you'll see more than one. When you see Bowes lines, you know that there have been periods of time during which nail production was interrupted. Nail production is interrupted during periods of severe illness or injury. So when you see those transverse lines, you ask the patient about their history over the last 6 to 18 months, and you're going to find out, oh yes, I was in the hospital, I was really, really sick, whatever. So nothing to be done, but patients will frequently say, why do I have that? You can explain, well, were you sick? Have you been sick over the last 12 to 18 months? Onychoschisia, again, not serious. I think a lot of nurses have this, and this is just splitting of the nail. Tends to occur when the nail is overhydrated. So just splitting of the nail. I remember that because schizoid to me means kind of split personality, so onychoschisia, splitting of the nail. Clubbing usually refers to the distal digit, not the nail itself, and that's typically seen with chronic hypoxic conditions. That's when it's usually seen, and I don't think they'll ask you that. Koilonychia is spoon-shaped formation of the nails. It's particularly easy to see here. This one has it, this one has it. So sometimes you will have patients where the nail is very adherent in the center, and on the edges it's actually starting to lift away a little bit from the underlying nail plate. Much more common in the elderly population. Sometimes you might see it in patients who have reduced perfusion, but more due to aging. Now let's talk about some that have major implications for management. I'm going to go back here. Clubbing, this is an observation. If I see clubbing and other indicators of hypoxia, I'm going to be sure the patient gets referred. No direct implications for the care I provide. Koilonychia, the spoon-shaped nails, no. I just want you to know what it is. But C-shaped or tile-shaped nails, major implications for management. These are your patients who are high risk for development of ingrown nails. So you can see why a lot of us call these C-shaped nails, because that's exactly what they look like. They look like the letter C, because they curve down on each side and come up in the middle. And of course, they're trapping tissue in between and tending to dig into the tissue on each side. C-shaped nails, easy to remember, very descriptive, but you should also know the term tile-shaped nails, because that's the other term that's sometimes used. You should also know plicatured nails. So plicatured nails are nails that are literally curving down into the soft tissue, much more common when you've got that C shape. At this point, they're not causing trauma. A plicatured nail is not yet causing trauma or infection, but it is curving down into the soft tissue and creating the potential for trauma and for infection. So when you have these tile-shaped plicatured nails, you have to worry that you're going to end up with soft tissue trauma and infection. And a lot of times what we will do for patients who have this shaped nail is we will take a little strip of an alcohol wipe and we'll tuck it under the nail on each side. We'll talk more about that under management. But clearly what we're trying to do in that case is we're using that little strip of alcohol pad as a spacer. We're putting it between the nail and the skin to keep the nail from growing down into the skin. Pterygium is when there's abnormal adherence between the nail and the skin, either at the proximal end of the nail or the distal end of the nail. When we talk about the free nail border, when you're evaluating that nail, you should be able to take an orange wood stick or a spatula and just slide it underneath that free nail border. But when you have a pterygium, the nail is literally fixed to the skin, and it's very difficult to identify a free nail border, and there might be nothing to clip. You might simply file. A totally separate issue is callus formation. See how you have all this callus formation of the distal toe, and many times the callus runs all the way up to the nail, and you can't even begin to trim the nail until you pare down the callus. So when we talk more about management, we're going to talk about take your scalpel, take your orange wood stick, find your free nail border. If you cannot find your free nail border, take your scalpel, pare away the callus, then look again for your free nail border. Critical element. Splinter hemorrhages we talked about. Here's a splinter hemorrhage. So if I see anything black under the nail, I'm thinking, you know what, it's probably due to trauma. A lot of times when I say to the patient, did something happen to your nail? Did you drop something on your foot? Oh, yes, this happened. I stubbed my toe, I dropped this on my toe. Sometimes they say, no, not that I remember. If I see something under the nail, I don't have a clear history of trauma, I'm going to follow up. I never ever want to miss a melanoma. Very, very important. Subungual hematoma simply means a collection of blood underneath the nail that occurs with trauma. You know, if you've ever had this happen, it can be acutely painful because you've got all that blood trapped between the nail plate and the nail bed. And so this won't be on the exam, but I'll just tell you what you can do if this happens. You can take paper clip, gem clip, and you can flame the end of it so that it's very hot and just put it on top of the nail plate. It'll penetrate the nail plate and allow the blood to escape. It's painless and it feels so much better. Onychomedesis and onycholysis. This is when the nail plate begins to separate from the underlying nail bed. Onychomedesis is separating at the proximal end. We don't see this a lot. I have seen it in a few patients. This is usually due to illness or injury. So you can see how the nail is not adherent at the proximal end. So you've got the cuticle and the nails lifted. Not seen so much. Onycholysis is seen a lot because that's very common with a fungal infection. Fungus breaks down the bonds between the nail matrix and the nail plate, between the nail bed, not the matrix, excuse me, between the nail bed and the nail plate. You can see it. See how your free nail border comes all the way down here? See how your free nail border comes all the way down here? So a lot of times when you're evaluating the nail for a patient with a fungal infection, you take your spatula or your orange wood stick, you're checking the free nail border, and it just keeps going. Because the fungus has broken the bonds between the nail plate and the nail bed, and the nail is literally separated. Do we take off all the way down to the base of the free nail border? No. We take off the distal nail. We usually take off any nail that looks like it could get caught and pulled off traumatically. But you don't have to take off all of this. You can leave some of it. I just want you to know what onycholysis is and what causes it. Onychomycosis is probably the most important term. Tinea pedis, onychomycosis. Tinea pedis, fungal infection of the skin. Onychomycosis, fungal infection of the nail. So onycho means nail. Mycosis, as you know, means fungus. So when you see onychomycosis, fungal infection of the nails. Some patients, as we've already said, are higher risk than others. Certainly your diabetics are higher risk. Elderly seem to be higher risk. Bottom line, onychomycosis, fungal infection of the nails, causes a whole spectrum of bad things. So it can make the nail thicker, almost always makes the nail thick. It can make the nail crumbly or brittle. So sometimes when you're providing nail care for a patient with onychomycosis, you literally have a piece of nail just fly across. That's why we have to be very careful, because the nail's so brittle. Other times you're trying to trim the nail or thin the nail and it's literally just crumbling apart. So it can cause thickening, it can cause crumbling, it can cause onycholysis, separation from the underlying nail bed. It can cause significant discoloration, yellow, brown, black. All of these are as a result of fungal infection. So here you have a nail that's very thick and hard. Here you have a nail that's very discolored and brittle, yellow and crumbly, thick and yellow brown. So fungal infection makes ugly nails. Fortunately, it doesn't cause pain. Fungal infections of the nails doesn't cause pain. Nothing bad is going to happen. It's just, as some of my patients have said, they're so ugly. Well, we can make them look better because we can thin and trim. So what you see here is a fungal nail that's been thinned and trimmed. So what can we do to treat fungal nails? Well, of course, we can refer to a podiatrist or to their internal medicine physician if they want to do systemic treatment. That's going to typically involve blood studies to monitor liver function, but that's certainly one option. There are some over-the-counter treatment options that are low cost, no risk, but of course take a long time. Some of them are listed here. Vicks Vapor Rub, but not just Vicks Vapor Rub, any menthol chest rub. So tea tree oil we mentioned, there's a product called Clear Nails. So there's a number of over-the-counter options for treating nail fungus that are very safe and inexpensive. And then the last thing I wanted to mention is some skin and soft tissue conditions that are tied in with nail problems. Paronychia is an infection of the nail folds. Paronychia almost always occurs because of an ingrown nail, but you might also see it in someone who bites their nails way down. So they'll say, I bite my nail to the quick. Well, of course, you know the quick, also known as the hyponychium, is the point where the attached nail ends and the free nail border begins. If people bite their nails down to that point, they can bite their nails past the point of attachment. Now there's access to the underlying tissue. And so they can get an infection. People who cut their cuticles or pick at their cuticles can get an infection anywhere along the edge of the nail. But most commonly is due to ingrown nail. So I'm going to show you several. So here's ingrown nail here, 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 here. When the nail truly penetrates the tissue, now we will call a nail ingrown, but what we really mean most of the time is it's a C-shaped nail, it's plicatured, it's curved down into the tissue, but it has not yet penetrated the tissue. When it penetrates the tissue and skin grows over it, now it acts as a foreign body, triggers an inflammatory response, and you can get bacterial invasion. So they can come in with acute erythema, induration, purulent fluid around that ingrown nail. At that point, The ingrown nail is usually referred to as onychocryptosis, where it's literally trapped underneath the skin. Onychocryptosis, the classic term for ingrown nail. Paronychia, the secondary soft tissue infection that occurs as a result of that ingrown nail. So I want to just summarize a few terms. C-shaped, tile-shaped nails just mean that the nail is growing in a C-shaped fashion. Plicatured nail means that the nail is growing down into the tissue and is becoming adherent to the tissue. It has not yet penetrated the tissue. Onychocryptosis is where the skin is literally growing over the nail. That is a true ingrown nail. That is when you also get paronychia. Now, we will talk more about management, but I'll just summarize here by saying that if you have a patient who comes in with an acute onychocryptosis, ingrown nail, and paronychia, if you are able to lift out the corner of the nail that is causing the infection, clip it away and smooth it, and then apply a topical antibiotic, and then send the patient on for further treatment, that can be very helpful and can provide some initial pain relief. If it's too painful for the patient to even tolerate that, you just send them on immediately for treatment. We'll come back to that when we talk about management. So in this session, we've talked about normal, and we've talked about common pathologic conditions affecting the feet and the nails, both systemic and local. In the next session, we will talk about assessment of the skin and the nails and management of common conditions. Thank you.